Hi there. Welcome to our program of digital slide review and surgical sign out. I'm Dr. Lewis Hassel, a professor at the University of Oklahoma Health Sciences Center, and our program is part of the Digital Anatomic Pathology Academy, a joint venture between the Digital Pathology Association and Path Presenter. In our program, we review a number of interesting and sometimes uncommon entities in surgical pathology to help you in your education and also to help enlighten and expand the differential diagnoses that you may consider. Our case today comes from the realm of GI pathology and is a result of a screening colonoscopy. A 55-year-old man who comes for screening and is found on the examination to have a small polyp in the sigmoid colon. This gets biopsied and reminds us that there are a number of things that sometimes look to be like polyps and aren't. We have to think that most commonly we're going to see adenomatous polyps, the tubulovillous adenomas and so forth, or serrated polyps or hyperplastic polyps and so forth. Occasionally we'll see some of the juvenile or other syndromic polyps like Peutz-Jeghers. And as occasionally happens, we also can see inflammatory lesions that look like polyps. But we need to remember that there are a number of stromal lesions that can also present with the appearance of polyps. Those can include submucosal lesions like lipomas or leiomyomas of the muscularis mucosa, maybe even mural lesions like GI stromal tumors and so forth, as well as a number of more subtle lesions, the mucosal Schwann cell hamartoma, perineurioma, ganglioneuroma, and occasionally other lesions as well. So this is the lesion that was presented in this individual. And as you can see, it's kind of a elongate polypoid fragment of tissue, but we're not seeing any of the usual epithelial lesions. We see a few lymphoid aggregates, which sometimes can be confused for polyps, especially if they're large and hyperplastic. But the glands here are all relatively straight and so forth. And I was just about ready to, sign this off as polypoid colonic mucosa when I noticed we had a little bit of a subtle change down here at the tip of this lesion. And looking at this, we can see that there's a little slight thickening of the muscularis mucosa, submucosa, and there's just a very subtle change here in the lamina propria that doesn't look quite like necessarily normal stromal cells. A little bit too pink, a little bit more spindly. I highlighted it with this particular field here, which shows this a little bit more dramatically in this situation. And so I was very suspicious based on this that this could be a mucosal Schwann cell hamartoma. But for completeness sake, we did a number of immunohistochemical stains, and I'll show those to you at this point. You can see here is a stain for CD117. As you can see, it's lighting up some of the mast cells here, but not at all touching this lesion in the lamina propria. Here, a stain for CD34, rule out GIST, or excuse me, GIST, or rule out solitary fibrous tumor. Again, we're not seeing much uptake here, just the normal vascular pattern. And another stain here we did was an epithelial marker. Some of those lesions in our differential and have epithelial markers. And here we'll go to the area in question. And you'll see that, again, the lamina propria is expanded, but it's not with anything that stains with keratin or EMA. And here, the stain with neurofilament, GFAP, just to rule out anything that might contain neurons, such as ganglioneuroma or perineurioma, and that also is negative. And so we get down here to another keratin. I think we'll skip this one and go directly to, ta-da, the stain that seals the diagnosis. Here you can see that our lamina propria is nicely expanded by S100 positive cells, confirming that this is indeed a mucosal Schwann cell hamartoma. Well, what is a mucosal Schwann cell hamartoma? Well, these are, as we've seen, a mucosal lesion, which can occasionally involve the submucosa, and they're usually located somewhat distally in the colon. Most of the time we see these in older patients because that's the population that's being screened, but probably they're present from a much younger age as well. The lesion is strongly S100 positivity, and the differential can include a variety of things, those things we've already mentioned, as well as perineurioma, which would be EMA or cytokeratin positive, ganglioneuroma, where you'd expect to see ganglion cells, neurofibroma, where you might see neuro GFAP positivity, epithelioid peripheral nerve sheath tumor, well, that's going to have a different morphology, the tactile corpuscle-like body, usually an incidental finding, and then the things we've mentioned, stromal tumor, solitary fibrous tumor, which uncommon in this location, but could project or be included if you had a fragmented biopsy. And the important thing to note here is that even if you miss this diagnosis, you haven't imperiled the patient. This requires no follow-up. It's a benign lesion and something that's going to have a favorable outcome and not require more frequent screening. So our final diagnosis on this little incidentaloma, mucosal Schwann cell hamartoma of the bowel. Well, we hope you enjoyed that. And if you did, please hit a like and subscribe to our channel so you'll be able to catch future releases from our channel. We try to release regularly and hope that these will add to your educational value as you work to become a top-notch surgical pathologist or just want to discover more about the pathology and the various organs that we talk about. So with that, thanks so much for joining me.